So fentanyl it can be a fantastic drug, especially for pain relief. And it's hospitals use it quite often. Some people even get it prescribed. It's been around for decades. It's very strong. Comparing it with heroin, it can be anywhere from 10 to roughly, I'd say about 25 times stronger than heroin. It is an opioid. But the problems that we're dealing with today isn't because pharmaceutical grade fentanyl is being diverted. Right? That's not the issue. I mean, we used to have an issue with OxyContin, right? A lot of that was people would get it being diverted. That's not really the problem that we're confronting today. The problem with fentanyl that we're dealing with is product that's illegally manufactured.
Hello and welcome again to another episode of Sacktown Talks. Today, we're glad to be joined by Beau Kilmer with the RAND Corporation. Beau, how's it going? Thanks for joining us.
Hey, glad to be here, Jared.
Yeah, can you tell us a little bit about yourself and kind of the RAND research group?
Yeah, so RAND is headquartered in Santa Monica. It's been there for about 75 years. And it's a nonprofit, nonpartisan research organization, which really focuses on trying to improve policy and decision-making through research and analysis. We've got about 1,000 researchers, a lot of them in Santa Monica, but we've got offices in other parts of the country and other parts of the world,
right.
Kind of working on all the major public policy issues of our time, ranging from the environment, the economy, labor, education, national security, homeland security. But kind of at the nexus of the work that we do on health and the criminal legal system, as well as social and economic well-being, we have our Drug Policy Research Center, which I co-direct, where we kind of work on all aspects of substance use and drug policy.
And so how did you get involved with RAND and kind of, researching this specific area?
So the long story is, I was really interested in drug policy when I was an undergrad. I grew up in Northern Michigan, was going to Michigan State. And I just was really fascinated by, how other countries were kind of how they were kind of dealing with their drug problems, how it seemed to be a bit different from what we were doing in the United States. So, it didn't matter what class it was, whether it's economics, rhetoric, whatever it was, I was writing about drug policy and written a couple op-eds here and there. And then, at one point I thought it might be kind of interesting to see what it's like to work at a place that just does research on drug policy.
Right.
So this is 25 years ago. And so, there weren't a lot of organizations, and most of the organizations that were in the space were either very much kind of pro-legalization or kind of anti-legalization. And I didn't really fall into either of those camps, but I thought, well, what the heck? It's just a summer. So I sent out a bunch of cover letters and packets and whatnot. And I was about to take a position with an organization, and then I stumbled upon RAND. I had never heard of the organization, but then, I was kind of digging around the website, and I saw that they actually did research on drug policy. So, I kind of submitted my materials there, and I got lucky for two reasons. One, it turned out that the woman in Santa Monica who kind of opened up my package was from Indiana. So we kind of had this Big Ten connection, and then also, it turns out there were a couple people who were at RAND who had just left there that had started a book and on drug policy, and they were running really behind. So I think this woman thought, well, heck, maybe if we could bring this kid out for 3 months, to kind of do all the unfun work on the book and the footnotes and references and all that stuff, maybe we can move this along. So anyways, they said, hey, do you want to come out to Santa Monica? And, I've never been to California before. So I road tripped out.
Like, yeah.
I was like, yeah, my girlfriend, we just had a great time. And, but anyways, when I got to RAND, I got to meet all the people, and I really enjoyed, the people that I met and the kind of projects they were working on. And, at the end of 3 months, they said, well, would you be interested in kind of continuing to work for us? We'll give you a computer, you can work remotely. And I thought, of course. Here I am. I'm back working like 3 jobs on campus for $5 an hour, right? Wait, you're going to actually pay me California wages to do research, to help do research on all these kind of, to address all these really interesting questions. So I stayed working with RAND. And so even when I was finishing up undergrad and doing my master's and my PhD, I was primarily working with folks at RAND. As I said, I really enjoyed working with them. I thought they were asking the right questions, and as I got more skills, I was able to do more. And so when I finished up with school, 15, 16 years ago, I knew this is where I wanted to be. So I've been working here full time ever since.
Yeah, that's awesome. We were just talking to someone like if you go to school and you have a certain major, it's kind of like, well, how do you get a job? Like, what are you supposed to do?
Yeah.
A lot of people become teachers or go to law school, but yeah, if you can research for a living, that's awesome.
Yeah, well, I mean, that was the interesting thing. And so I was an international relations major, thinking, really focused on poli-sci. And, after the summer at Rand, I didn't know that there was this whole field of study, with respect to public policy and public administration. Right. And so I got back to Michigan State and I thought, well, I could, either try to take more classes here or just finish up and then maybe try to look into a master's program. And then so I was very fortunate. I got into the master's program at Berkeley. And so pretty much have been in California for most of the time ever since.
Oh, so that's awesome. So you've been going to school and working for Rand kind of at the same time for quite a while then.
Yeah. I mean, there were some times when it was only, working at nights here and there, but right. No, it was really helped, during school, I'd come down there for the summer, that type of thing. And, kind of helped with some of my dissertation research. But I've got to say, it's so interesting how things have changed. And, so for someone that does research on drug policy, it used to be the case that if you wanted to learn about kind of other approaches, a lot of what you were doing was kind of looking at how things were implemented in other countries. Right. But, especially, the past 10, 15 years, there's actually just been a lot of variation in drug policies within the United States. So it really has opened up the opportunities. And it's actually been great because, because of these changes, there are a lot more people kind of doing research in this field, which I think is fantastic.
No, it's very interesting. We've had Scott Wiener on a couple times and talking about some of the things he's trying there in San Francisco. And then I was on Twitter and I saw he was on Dr. Phil and he was arguing with some other guy on Dr. Phil about this stuff. Kind of what do you think about some of the policy, things that we're taking a look at, trying to change things? Like what does the research show about some of these things like, having what do they call safe injection sites, for example?
Yeah. So you got safe injection sites. They're also referred to as drug consumption rooms or supervised consumption sites. Mm-hmm. They've been around kind of outside of the United States for decades, a number in Europe as well as in Australia, and a number have opened up in recent years in Canada.
Right.
And so I gotta say, it's probably about 5 years now. With some colleagues, we kind of did a deep dive into really trying to figure out, well, what does the research say about these supervised consumption sites? Because there have been multiple reviews out there that said, there's 70 peer-reviewed studies. They're all quite positive. And so we kind of got under the hood and kind of really looked at all these studies. And it turns out that look, most of what's been written has been quite positive. There's no denying that. But what's somewhat problematic about the research is a lot of it doesn't necessarily allow you to determine whether or not, participation, in the supervised consumption site kind of led to this good outcome. Right. And so when we kind of looked at all the studies, we identified, maybe 10 that we thought actually were pretty decent in terms of having kind of realistic control groups. Right. So we could actually then begin to get a better sense of, well, how much of this change that we're seeing is attributable to the supervised consumption site versus potentially some other reason. Right. And I've got to say, so in terms of, so a lot of this research is kind of looking at, well, what happens in the community? When a neighborhood opens up a site, how do outcomes change compared to maybe neighboring communities or other neighborhoods? And so, there was some early research coming out of Vancouver, where Vancouver, they now have multiple supervised consumption sites, but back then they only had one or very few. And, and this was a paper that was published in The Lancet, so arguably one of the world's best journals. Right. And it found that after that supervised consumption site had opened up, that there actually was a reduction in deaths around that neighborhood, and it had, decent control groups. Now, there was another study that kind of took a similar approach that looked at what happened when they opened up a supervised consumption site in Sydney, Australia. And that one, they didn't find that it led to a reduction in deaths around the neighborhood, but that it did lead to a reduction in the number of kind of ambulance call-outs, right? So in terms of the number of people overdosing. And, but in terms of kind of outcomes with respect to crime, that's where there's a lot of debate. If you allow one of these centers, is it going to increase crime? I'd have to say, of all the research I've seen, nothing suggests that opening one of these centers up increases crime. In fact, there are a couple of studies that suggest that it reduces them. But the thing you have to keep in mind is that most of this research was done in places that, times and places that weren't affected by illegally manufactured fentanyl.
Right.
But the other thing we do have to keep in mind is, there have been millions, literally millions of injections that have been supervised at these sites. There have been, thousands of overdoses that have been addressed. And then kind of in the brick and mortar facilities, I don't think anyone has ever died. And so anyways, the issue here in the United States, there are a lot of places that want to do this in the US. And in fact, New York actually has a few supervised consumption sites that they've opened up. There's been a lot of conversation about this in San Francisco. I mean, they had that Tenderloin Center, which ended up kind of serving as a supervised consumption site. But for the most part, there really hasn't been a lot of action in the United States with respect to supervised consumption sites because of federal law. And long story short, under the Controlled Substances Act, essentially there's something called the Crack House Statute, which suggests that, if you've got this facility and that people are using drugs there, you could be held liable and it's illegal. And so over the years, as different communities have talked about opening up supervised consumption sites, folks from the Department of Justice would, send out memos, write op-eds, even sometimes file lawsuits saying you can't do this. And so it's going to be really interesting to see kind of how this continues to play out at the federal level. Obviously one thing, and I do think because of the federal law, that is holding some jurisdictions back from even experimenting with this. So, there are a couple of different things that could happen. I mean, in theory, you could pass a bill, making these supervised consumption sites exempt from the, Controlled Substances Act. I can't imagine that actually passing anytime soon in DC.
Right, with the politics as they are.
Yeah. But, the other thing that they could do is, especially if you're going to allow states and localities to experiment, kind of given where we are with this overdose crisis. The other thing they could do is treat the supervised consumption sites like we deal with cannabis. Right? Cannabis is still all illegal under federal law. Right. Remember, and it wasn't, when Washington and Colorado passed in 2012, no one was quite sure what the federal government was going to do. And, it wasn't until later in 2013, Department of Justice came out, they issued a memo and said, look, hey, this is all illegal under federal law, but as long as you're following these different guidelines, it won't be a priority for us to kind of target you. And this was referred to as the Cole memo. And even when Trump got into office and that memo was rescinded, for all intents and purposes, the federal approach didn't change. The feds have been pretty much hands off here. So that you can imagine that they could do something similar with respect to supervised consumption sites. They could put out one of these memos saying, look, we believe this is illegal under federal law. However, if you're following certain guidelines, it won't be an enforcement priority for us. And so, it'll be interesting to kind of see how this plays out. But that's just kind of one example of kind of harm reduction that gets a fair amount of attention. While there's a lot of discussion in the U.S. about these fentanyl test strips, right? I mean, some places still prohibit them, but a testing strip essentially, you could determine whether or not you're heroin or you're cocaine or other substance, whether or not it's just a binary yes or no. Whether or not you've got whether or not there's fentanyl kind of in that sample. There are other approaches where you could actually with drug checking, where you could actually do more sophisticated tests, where you could get a better sense of not only, is there fentanyl in this, but how much fentanyl is there? And so you see a lot of work kind of being done on that in Canada as well, kind of taking this to the next step. And, so that obviously not only provides information to the people who use drugs about kind of what they're consuming, but it also provides a lot of information, for those in public health and those doing research, getting a sense of actually what's in the market. Right. I think that's one of the, there's a lot of sad things that have come with this overdose crisis. But part of what's frustrating as a researcher is, we don't know how many people use heroin. We don't know how many people who are using illegally manufactured fentanyl. We used to have that information. In fact, I led the team a couple of times for the White House Office of National Drug Control Policy to actually estimate those numbers. And it takes information from a lot of different data sets to do that work. And unfortunately, of all those different data sets, there was one. It was called the Arrestee Drug Abuse Monitoring Program. And we don't usually say abuse anymore, that stigmatizing language, but that was the name of this program. It was referred to as ADAM. And this was a data system where they actually interviewed people who were in jails. It didn't matter if you were there for a drug offense or not, and had nothing to do with their case. But they would ask you questions about, what drugs have you been consuming? How much did you purchase? What did you pay for it? It provided really rich information about kind of what was happening in these markets. And at one point it was operating in 40 different counties throughout the United States. So it was a really useful data source for a lot of different reasons. But the program ended up getting officially cut in 2013. So here we are, in 2013, that's when things really started to pick up with illegally manufactured fentanyl. And the thing which was interesting about this ADAM program is that not only did it, did they ask a lot of questions, to the people who were incarcerated, but then they asked them if they'd be willing to submit to a drug test. Because this was right after they had been booked. And so, it would have nothing to do with their case, but it would allow the researchers then to kind of validate kind of whether or not they're being honest, but also to get a sense of kind of what substances they're using that they may not know that they were using. And, most agreed to it. So I just think back to, wow, if we actually had that program still in operation today, we would have been able to get a much better sense about kind of the spread of fentanyl, of illegally manufactured fentanyl and other synthetic opioids a lot earlier. We'd have a much better sense about the total number of people who are using, which is really important information to have. I mean, think about in terms of resource allocation, in terms of trying to measure the effectiveness of different programs. I mean, this is very basic information that we just don't have. And so, the United States, we kind of used to be a leader when it came to kind of the drug data infrastructure. That's no longer the case.
It's interesting. Like I remember in 2016, you heard about this opioid crisis, and now all we hear is fentanyl. Yeah. What is fentanyl? What is it going into, and why is it a crisis? And why didn't we hear about it until 2 years?
Yeah. So fentanyl is it can be a fantastic drug, especially for pain relief. And it's hospitals use it quite often. Some people even get it prescribed. It's been around for decades. It's very strong. In terms comparing it with heroin, it can be anywhere from 10 to, roughly I'd say about 25 times stronger than heroin. But it is an opioid. But the problems that we're dealing with today isn't because pharmaceutical grade fentanyl is being diverted. Right. That's not the issue. I mean, we used to have an issue with the OxyContin, right? That a lot of that was people would get it being diverted. That's not really the problem that we're confronted today. The problem with fentanyl that we're dealing with is is product that's illegally manufactured. And so, the United States, we've had, people started really talking about this, Jerry, right, kind of 2014, 15, 16. I mean, we had other, isolated incidents in the past where, there might have been one chemist in Mexico who was actually producing fentanyl and made it to the United States. It ended up killing a number of people, but then they were able to go shut down that one lab or, that one person. Right. So there have been kind of, some isolated incidents, but things really started to change right around 2013. And at that time, it was believed that most of the fentanyl that was then coming into the United States was coming from Mexico. I'm sorry, it was coming from China. So it was being produced there, and then it was being shipped over, to the U.S. And then early on, what we ended up seeing was that it was being mixed with heroin. So people would, they would get a bag, and they would think it was heroin, but it turns out there may just be a little bit of fentanyl in there. And because fentanyl is so strong and it's so cheap to produce, it makes it a lot easier. So if you've got a kilo of heroin or whatever, you sprinkle in a little bit of fentanyl, that's going to go a lot further. So, from a drug dealer's perspective, it makes sense. So what we started seeing is, 2013, 14, 15, especially on the East Coast and parts of the Midwest, you were hearing a lot more about people, who were, who ended up overdosing. They didn't necessarily know that they were using fentanyl. You could really think about this more like a poisoning crisis. No one was, and very few people were asking for fentanyl.
Right.
It was just kind of showing up. So that started kind of picking up, and then we began to see, it began to move, from the East Coast, Midwest. It started to move its way west. Then I would say right around 2018, 2019, that's when the Mexican drug trafficking organizations got a bit more involved, or a lot more involved, I should say. So it's believed that
they're like, oh, it's a business opportunity.
Oh, totally is. Yeah. It's, because as
new
I
wave
said,
coming.
Yeah, yep. And so it used to be the case that you need your precursor chemicals in order to kind of produce it. And so those chemicals were produced in China, then they would kind of produce the fentanyl there, and then they would ship it over. Well, what ended up changing, right around 2018, 2019, is that, the Mexican drug trafficking organizations got much more involved in production. So they were importing the precursor chemicals from China, but they were producing the fentanyl in Mexico. And so, it would either be kind of mixed into powders, or, you were seeing a lot more in terms of the counterfeit pills. There have been issues with counterfeit pills before, but then you begin seeing a lot more in terms of, people thinking that they're taking an OxyContin pill. They think they're taking a Xanax,
right,
but actually it just got filler and it's got some fentanyl in there. And so you saw this kind of change in production, but then also, in terms of kind of the way the market was. So you still had it being mixed in with heroin, but then, there are some places now kind of, especially on the East Coast, where it's actually kind of hard to find heroin, because, fentanyl just kind of dominated and it was cheaper. And then also, people, it really kind of, people became more tolerant. So it would cost a lot more to try to kind of maintain that habit if you were getting heroin, as opposed to doing it with fentanyl. So you had a couple different things happening. So then, so you had it was being mixed in with heroin. Then you saw more kind of happening with the counterfeit pills, and that's still is killing a number of people today. And that's, especially for people that are opioid naive. You go to a party, you think you're taking this kind of pill that someone might have gotten from someone's bathroom or whatever, and it turns out that it actually was illegally manufactured. But then you've also got, and we hear more about fentanyl being kind of mixed in with other drugs.
Right.
That's pretty hard to measure, especially if you're analyzing the death data. And so I've been doing some work with some other colleagues. And so we could see, okay, when someone died, did they have fentanyl in their system? Did they have cocaine? What other drugs did they have? And definitely there, most of the people that are dying, they have multiple drugs in their system. But those data don't really tell you about whether or not, the fentanyl was mixed in with the cocaine, or someone did cocaine the day before and then did fentanyl that day and then overdosed. But you are hearing more about it being mixed in, and definitely, for people that are using cocaine and some of these other drugs, it definitely would make sense to be using these fentanyl test strips to make sure there's no fentanyl in there.
Just to kind of get a scope of the fentanyl issue, like how many people are dying per year of fentanyl overdoses right now?
Oh, so nationally, I think we're at over I want to say 105,000, somewhere around there. So slightly above 100,000 people are dying from drug overdoses each year. I think it's roughly around 2/3, 70% of these involve what's classified as synthetic opioids other than methadone. But in general, that's this illegally manufactured fentanyl. So it's killing a number of people. And the other thing, Jared, I wanted to talk about is, and what we see definitely like in parts of San Francisco, is you then had a whole market where people were just looking for fentanyl.
Oh, so now people are looking for it. Okay.
Oh, yeah. Well, so that's how things have changed. And so the dynamics in San Francisco, which I'm most familiar with, it's been really interesting. And so, fentanyl didn't hit here. It took a while for it to hit, but when it did enter the market, it wasn't necessarily being mixed in with heroin, right? It was a whole kind of separate market, so a dealer might have heroin in one pocket to sell you and would have fentanyl powder in the other. And there are a lot of different kind of hypotheses for this. Part of the reason is that on the West Coast, the heroin use is usually black tar, whereas on the East Coast, it's usually a powder. So with a powder, it's a lot easier to kind of mix the fentanyl in. So anyway, so some people thought that may have been kind of potentially a protective effect in terms of delaying when fentanyl kind of hit the market in the West Coast or on the West Coast.
Oh, interesting.
But yeah, now it's in San Francisco. You had, I mean, I think for a while there you had it still may be the case, like a couple people overdosing and dying every day.
Yeah,
it's roughly.
Yeah, so we have a new legislative session's coming. We got a whole bunch of new members coming in, and a lot of them are talking about, hey, we want to solve this fentanyl crisis. We got to do something. What should they be focusing on? What does the research say?
Oh, wow. So there are a lot of different things that I think could probably help, but there's no single solution.
No silver bullet out there.
No, there's no silver bullet. I mean, the other thing to keep in mind is, so we were trying to estimate just, how much fentanyl, illegally manufactured fentanyl, is actually consumed in the United States, right? And so, long story short, thinking about this in terms of the pure amounts, our best estimate was that around 2021, that the total amount of illegally manufactured fentanyl, that kind of in terms of it, that's 100% pure. So the kind of pure metric tons in consumed in the country, we're talking single digit metric tons. Let me put this in perspective. The last time this was estimated for other drugs was 2016, when it was believed there might have been 150 to 200 pure metric tons of cocaine used. For heroin, it was probably closer to 50 pure metric tons. Here we're talking about single digit pure metric tons. So, I mean, supply reduction was already difficult beforehand. So, it's just so pure and it's so compact that, thinking that you're going to be able to eliminate the supply is that seems very unrealistic. But so in terms of what could be done, definitely, this idea of really innovating, we wrote a book on this, 4 years ago, really kind of saying, look, we need to pay attention to this. We kind of looked at what had happened in some other countries. So look, we need to think about this more like a poisoning crisis than a traditional drug epidemic. And if you think about it more as a poisoning crisis, it really should kind of open up other policy solutions, or at least different things you should try. And so, for example, the supervised consumption sites, that's not going to solve the problem, right. But it could help in some places. Same with the drug checking services. So there are some things that, it'd be worth trying, those are a couple of different examples. But I mean, the most important thing is we need to continue to provide access or increase access to high quality treatment. And here, funding is necessary, but it's not necessarily sufficient, in that it's not just, yes, funding helps, but we also need to make sure that we're not funding, treatments that could be doing more harm. For example, detox, we know follow-up, that type of thing. So money is important, but also, part of the issue is that so much of kind of when we talk about substance use disorder treatment, it's kind of done in this whole kind of specialty sector. It's not necessarily a part of kind of mainstream healthcare. That's starting to change a little bit with buprenorphine, where you can kind of go in and get prescribed that if you have an opioid use disorder. But we need to do a lot more in terms of integrating substance use disorder treatment with mainstream healthcare. And part of that is just kind of in terms of how it's funding, but also part of that is also reducing stigma and getting more physicians to learn more about, treating addiction and getting more involved. And so ideally, so you'd have more primary care physicians actually kind of helping to treat some of these individuals with substance use disorders, and then if that treatment doesn't work, then maybe at that point they could go more to the specialty sector. But yeah, by definitely kind of integrating it more with mainstream healthcare, it's not only going to increase access, but also I think it can help kind of reduce some of the stigma as well. But the other part is there are a lot of administrative barriers as well, and regulatory barriers, right? If you want to get access, if you have an opioid use disorder and you want to get access to methadone, you actually have to go to a separate clinic, and you've got to go there, once a day, and only after a certain amount of time will they even begin to give you some take-home doses.
Right.
And I mean, and that's just, that's not the case in other countries. So there's a lot of barriers. And then also at the end of the day too, when is treatment going to be available? I mean, I did some work. I was fortunate enough to be one of the facilitators for San Francisco street level drug dealing task force, and which brought a lot of people together that didn't necessarily agree. They had very different perspectives, but they were able to come up with a kind of a consensus number of recommendations. And one of those recommendations was making treatment available 24/7. Right. If someone like 11 o'clock at night, if they've decided, they don't want to use anymore, that they actually want to get buprenorphine or get access to some other medications, we should make that easy. We should make that more available instead of people. I think your only option may be to go to the hospital or go to the emergency room. There's some very basic things. So obviously, as I said, money for treatment is important, but it's not sufficient. We need to really kind of do a better job of mainstreaming addiction treatment with mainstream healthcare.
It's kind of interesting. Like you started studying international relations, and here you are. You get to use it. You get to see all these other countries. Where the drugs are coming from, who's doing good stuff, who's doing bad stuff. It's fascinating.
Yeah, I mean that's what's been really interesting. And the other thing about treatment is, in terms of there's certain the medications that we use to treat opioid use disorder in the United States. If you look at other countries, some of them use allow for other substances as well. So there are other medications. So you can think about it in some other countries, the physicians just have bigger toolboxes, right? So that's another thing too, making it easier to begin trying some of these other types of medications, because methadone and buprenorphine, they work for a lot of people. They don't work for everyone.
Right.
I mean, it's just like any other type of medication, right? Works for some people, not everyone. So sometimes you got to try something different. So I think there's a lot we could do in terms of just kind of looking at how, even just opioid use disorder itself, what are the other medications that are being used and trying them here in the United States.
What country out there is getting it right that, that we should, look towards or emulate or?
Well, it depends. I mean, Jared, that's a great question, but it really depends on kind of what type of problem you're talking about, right? I mean, so much of the focus is on, overdose deaths and opioids, which is important, but also we know that when we're talking about overdoses, stimulants and methamphetamine are playing a much bigger role as well in some of those overdose deaths.
But I guess kind of just talking to you, like what as a parent is the diversity of drugs and regional differences and things like that.
Oh,
like,
yeah. And Jared, and the thing that doesn't get as much attention is that alcohol is still our biggest problem.
Right.
In terms of substance, substance use and death and disease and violence. And so definitely the United States, overall, we don't do a very good job of regulating alcohol. I mean, obviously, when you get a beer, what's in there. But in terms of, the power of the companies, advertising, the prices are too low. So I've actually been doing some interesting research, now for about 10 years, kind of looking at this idea of losing your license to drink.
Right.
Right. So you think about it, right? When you turn 21 in the United States, you essentially get a license to purchase and consume as much alcohol as you want, which raises the question, what point should we maybe revoke or suspend your license, right? In terms of, when alcohol is leading you to repeatedly threaten public health, public safety, right? After you maybe get your third DUI, or after you've gotten arrested multiple times for assault because of alcohol. At what point should we revoke that license? And so, so I've been doing research on this program, which started in South Dakota almost 20 years ago. It's fascinating. And so, so it was about 20 years ago, the governor there put together this blue ribbon commission, trying to figure out a way to reduce incarceration. He didn't want to be sending more people to prison. He didn't want to build more prisons. So he brings together kind of all these different state leaders. And at the time, there was a new attorney general in the state, and who ended up being a part of this commission. And his name was Larry Long. So what Attorney General Long said is, look, before I was the Attorney General, I was also a prosecutor. And he was in this county that maybe had 2,000-3,000 people. And he said, the thing is so many of the people that are coming back to prison are coming back because of issues related to alcohol. And so, back when I was a prosecutor, when I would tell people, when I would, after like their second DUI or third DUI or, multiple offenses related to, violence and alcohol, it was, look, when I would tell people not to drink, as a condition of bond or as or it ended up being as a condition of probation, I would actually make them come into my office or come into the sheriff's office once in the morning and once at night, every single day, and blow into a breathalyzer.
Wow.
If there was any alcohol in their system, they would go to jail for a night. So the idea was to hold people accountable, but not necessarily, revoke their probation or, and have them go back for a year or something. So anyway, so this is something he was doing, I think, in the 80s, 90s. And so we said, hey, this seemed to make a difference in my small county. Why don't we try a pilot program? And, the story I've heard is people just kind of laughed at him. There's people have been drinking for 30 years. You're not going to get them to stop, let alone come in twice a day. But, he was the attorney general. And so he ended up, he knew a few judges and was able to get them to do a pilot program in South Dakota. Started in a few counties. And they were just kind of initially focused on people who had, was their second or third or fourth DUI offense. And sure enough, the people were coming in twice a day. And the vast majority, almost all of the tests, they were coming in, they weren't testing positive for alcohol. And so the judges, to be honest, I think were a bit surprised, but they were impressed. And so the judges, then they started freelancing. They're like, this pilot program was supposed to be for people who get arrested for DUI, but, I've got this person who was arrested for domestic violence. I know that alcohol was part of his issue. I'll send him to the program. So the judges started to kind of freelance. Then they started talking to judges in other counties saying, hey, I got this program, seems to be making a difference. And so the program began to spread. So fast forward to like 2009, 2010, I'm doing research primarily on illegal drugs. And someone comes up to me and said, oh, I know you're primarily working on cocaine and heroin and meth, but I got to tell you about this alcohol program. So he starts telling me about this program in South Dakota and how, in some places you would have hundreds of people coming in every morning and every night. Wow. And to be honest, my jaw just kind of dropped. I was a bit in disbelief. And, so after that conversation, I went to my boss at RAND and I said, hey, I just learned about this program. I don't know if this is going to turn into anything, but would you, kind of cover my time to go road trip South Dakota so I could kind of see this program in operation? And he's like, go for it. And, I made the mistake of going in the middle of February.
I was going to say, you didn't go in the winter, did you?
I did. Yeah. I mean, I'm from Northern Michigan, but, California maybe saw. Anyways, so I get there and sure enough, there are some counties. We did have hundreds of people coming in every morning, every night. There are some smaller counties where maybe you had a handful of people. But, kind of as I saw this program operating in, 4, 5, 6 different counties, it seemed to me like, okay, there's something to this, potentially. But what they actually need is an independent evaluation. So at the end of this trip, I go to the attorney general and said, look, what you need is an independent evaluation. And what that would mean is you'd have to open up your books to me, give me access to the data. You'd have no control over the results. But if you could promise me that, I could probably go to one of the federal agencies to try to get some funding to evaluate the program to see if it really is making a difference. And he was like, go for it. So anyways, so I did that, got some federal funding. And so, so for the past 10 years, we've been evaluating this program. And we found that it not only kind of reduces, obviously, repeat arrests for DUI, leads to reductions in arrests for domestic violence, also leads to a reduction in deaths. Right. And so some people are like, well, hey, that's just South Dakota. Can this work somewhere else? Well, they implemented the program in North Dakota, which, is pretty similar. We saw pretty similar effects there. We've evaluated the program in Montana, also seeing pretty large effects there. So it really does seem to make a difference for individuals. But I got to tell you, the program itself is controversial from a couple different angles. Some people don't like it because there's no treatment component. So this isn't like kind of a drug court, right? Where someone, they order you to go to treatment. This program just says, look, you need to come in and, blow into a breathalyzer twice a day. I mean, now some of the people that wear those alcohol monitoring bracelets, but essentially, so there's a number of kind of technologies involved now. But anyways, they're like, we just want you to, you just need to abstain from drinking. If you want to go to treatment, that's fine. We don't care. But and then there are other people that are like, well, hey, it's a night in jail. And could you do something, what if it was, do you have to incarcerate someone? And that's a really good question. I mean, the thing is it reduces, a significant overall lead to a net reduction, even if there are people spending a night or two in jail here or there, that to the extent that it's reducing all these repeat drunk driving arrests and convictions, right. Overall, it's leading to a bigger reduction. And then, there are other people too, because, in terms of, reducing drunk driving, there's those interlock devices, right? That you put them on the car, right? You have to blow into it, that type of thing. And so I've noticed that kind of, the folks that kind of are supportive of the interlock devices, they've always tended to dismiss this program, because this program isn't, because they're like, well, we need to focus on the driving. Whereas this program's like, no, we need to actually focus on reducing the alcohol consumption. And so I got to tell you, as a researcher, yeah. I'm like, well, let's compare them.
Right. So like, how many people die from drunk driving every year? Isn't it like millions?
No. Oh, no. I want to say traffic fatalities are somewhere each year. I want to say they're somewhere around 10,000, anywhere between 10 to 15,000. I don't know what share involve alcohol. It's a fair amount, but that's just a small portion, right? There are a lot of other accidents, right? And then
remember there was like a program. It was like every 15 minutes there's a alcohol related.
Yeah, it's no. I mean, alcohol crash. In terms of it's a leading cause of premature death. I mean, not just for accidents, but also excessive drinking in terms of links with cancer, cardiovascular disease, right? And so I mean, I think what this program does is, it's very different from the rest of the criminal legal system, right? When we think about arrests and prosecution, oftentimes it's kind of this black box. It's not very transparent. And, you could get arrested for a DUI and it might be 6 months before you have your case, right? This program is very different and that is extremely transparent. It says, look, here's what you're going to do and here are the consequences. And so it's kind of referred to as kind of being swift, certain, and fair. Right. They're not going to revoke your probation and have you go back, and spend 2 years behind bars or something. But the idea is to really hold people accountable. And, some of the research we've done at the individual level suggests that for some individuals, even after they're done with the program, it does seem to be affecting their behavior afterwards. Right. So you can imagine that some people, once they're done with the program, they may go back to drinking the same amount that they were drinking before. There could be other people who may who may go back to drinking, but maybe not drink as much. Right. And then there could be some people that just, they're like, you know what, I'm done. And so there's a lot more to learn about this program. And I mean, the big question for me is, can this actually work in a more urban environment?
Or can it work with other substances as well?
Yeah. And so there is a program that was similar to this. It was kind of started at the same time in Hawaii, but it was largely focused on illegal drugs. Mm-hmm. It did really well in Hawaii. They tried replicating it in parts of the United States, and they tried to implement this program in 4 different areas. In general, it didn't necessarily kind of reduce arrests, reduce convictions, kind of what you saw in Hawaii, but it did reduce substance use. So it can work. I got to tell you though, if you were going to do this program today, you got to be real careful with opioids, right? Because you get somebody in this program and say, they reduce their opioid consumption for a while. And then if they go back to the market and their tolerance is down, and just the opioid market today is just so deadly and dangerous.
Oh, interesting. Yeah.
So you have to be real careful. Like I think, for other substances, I think it makes it's worth trying. The thing is I don't know if this is going to work in every place. I doubt it would. But, the evidence that we've seen so far suggests that it's worth considering. And in fact, there were some bills in California, 2016, 17, 18, to try a pilot program. Never made it through. But yeah, I mean, I just thought it'd be interesting to kind of see, can this type of, as I said, there, some people do the twice a day testing. Other people will wear those alcohol monitoring bracelets. Right. That, they test your sweat every 30 minutes for alcohol. And there are other devices. I mean, look, at the end of the day, these technologies are just going to keep getting better and cheaper, but it's what we do with that information that ultimately determines whether or not, it affects public health and public safety.
Yeah, like your Apple Watch can do so much. I'm sure.
Oh yeah. Yeah, exactly. And so it really is this idea of saying, look, when you turn 21, you kind of get this license to, purchase and consume as much alcohol. But, this is a program that's really targeted at people who have repeatedly threatened public health and public safety for their alcohol use.
Right.
And because of that, it's not, someone who just has an MIP, and it's usually not for people your first DUI. Right. So anyway, it's an interesting kind of approach. And so, it'd be interesting, to see whether or not this would work in other areas. But there's so many other kind of questions I have. This is a program, it, creates a deterrent effect, but it's really all about the stick. Right. If you have any alcohol in your system, you go to jail for a night. Well, we also know there's a lot of research on what's called contingency management, which focuses much more on positive incentives. So what if you had it to where not only, so yes, if you test positive for alcohol, you go to jail for a night, but if you go 2 weeks without testing positive at all, maybe we give you like a voucher to go to a movie or for a fast food meal. I know that may not sound like it would make much of a difference, but there's a tremendous amount of research that's been done on what's called contingency management that actually shows that people, even those that have substance use disorders, that they will scale back. Some of them will scale back their consumption. In fact, you hear a lot of people talking about that approach in terms of dealing with methamphetamine use disorder in California. So there's questions about, if you added positive incentives, could it make more of a difference?
Right.
Also, what is the minimum level of sanction that you need to create this deterrent effect? As I said, the way they've done it there has been, a night or two in jail. Well, what if it was 6 hours in jail? Or what if it was house arrest? What if it was something else besides, a full night, in a holding cell? So there are a lot of different questions I have, and as a researcher, I'd love to have an opportunity, to figure this out.
It kind of in your ideal world, if you were to do a pilot here in California, kind of where would that be and how would you set it up? And how much would it cost?
Yeah, well, that depends. Obviously, and I've tried doing some of these kind of, setting up. Essentially, what you want is what they would call a randomized control trial, right? This is what we do with medications with the FDA, right? Someone has a particular condition, they randomly assign. Some people actually get the drug that's being investigated. Other people might get a placebo, and then they kind of look at their outcomes, right? They randomly assign them, and that's how they kind of that allows you to kind of rule out what they refer to as selection effects, and kind of allows you to rule out alternative explanations if you're randomly assigning who gets this. So ideally, it would be great to do a pilot, somewhere in California, where you actually have the opportunity where you could randomly assign people, to where maybe some people get, kind of the sanction that they typically would get now for DUI, and then other people could be part of this 24/7 program. Or, the other thing you could do is, it'd be interesting that, for those who would, typically get interlock devices, right? Randomly assigned. Okay, these, of these people, of everyone in a particular county, it's their, second DUI, for example. For those, and if they were typically, some people would get randomly assigned to interlock, other people would get randomly assigned to this 24/7 program. And then we would follow them over time and obviously not only kind of look at what happens in terms of arrest for drunk driving, but you'd also want to look at, arrests for domestic violence, other types of violence. So you'd want to look at more than just kind of what happens. And then, if you had a lot of money, and then it'd be really interesting to kind of look at, even within the people that are doing the 24/7 sobriety program, I have questions about, who does better? Those that come in twice a day, or, versus those that maybe wear the alcohol monitoring bracelet, versus those that use other technologies. So I think that's another question I have too, in terms of figuring it. And my guess is that certain types of testing and certain types of regimes work better for different types of individuals. But we're never going to really know that unless we do the research on that. Right. And so as I said, there was some movement to at least try a pilot program in California for a while. I don't know if it's going to come back, but we've continued to kind of do research on this in multiple states, and in fact, in the United Kingdom, kind of based on our research, they started a program. They refer to it as mandatory sobriety, which isn't it isn't identical to 24/7 sobriety, but it's pretty similar in that they're, people who have alcohol related offenses, they've got to wear the monitoring bracelet for up to 4 months. And I don't know if the program just kind of started there. So I don't know if anyone's doing an evaluation. They don't necessarily, it's a lot harder to kind of have this swift, certain, and fair sanction, right? They're much more likely to have warnings. And so you would think that it may not have as much of a deterrent effect, but that's an empirical question. But anyways, obviously it's going to be implemented in some, more urban areas there. So someone will pay attention to, but it's, as I said, I don't know if this program's going to work,
only one way to find out.
Yeah. And trying to figure out, and especially in urban areas, it would be fascinating to see if this can make a difference.
That's really interesting. So much has been tried over, the past, 50 years on drugs and substances, just say no, close the borders, build a fence, legalize everything. Kind of what do you see? What policies actually work, and what policies should we, put our funding behind and seriously consider?
Now, that's a great question. And at the end of the day, one, it depends on the substance that you're talking about. And it also depends on kind of your values and goals, right? So, that's the thing. So, I'm a researcher at RAND. We don't come out and say, oh, you should legalize or you should not legalize, or you should do X or you should not do Y, right? A lot of the research that I've been doing, starting in California, 12, 13 years ago, is really trying to help jurisdictions understand that if you're going to go down this pathway toward looking at these alternatives to prohibiting, for example, cannabis supply, you're going to confront a number of choices. Right. And the kind of the decisions you make along the way are ultimately going to influence how this affects public health, public safety, and social equity. Right. And so with respect to cannabis, it's interesting within the United States, when we talk about legalization, we're usually talking about the kind of let's regulate cannabis like alcohol, for-profit commercial model. That's what gets most of the attention here in the U.S. But it turns out that if you're looking for alternatives to prohibiting cannabis supply, there are a number of kind of middle ground options that you could consider, right? To where you could reduce arrest, allow for some access to supply, but not necessarily have a full commercial market. For example, you could just allow home grows, you could do cannabis social clubs. You could even potentially have a state monopoly where you have state stores selling the cannabis products. And in fact, that's what, and we still have some places that do that for liquor here in the United States. And in fact, there are some places in Canada that's what they've got it kind of using a state store model. You can imagine, you could also limit the market to nonprofit organizations, or even if you're going to allow for-profit companies to get involved, you could at least require that they be kind of for benefit or B Corps, right? That focus on the triple bottom line of people, planet, and profit. So there are a lot of choices there. I got to tell you, in the United States, those middle ground options don't get a lot of play. When I talk to people and talk to jurisdictions outside of the United States, there's much more interest in these middle ground options. Even when I talk, especially in Europe, even when I talk to folks that are very much kind of in the legalization camp, they ask me what are you guys doing in the United States? Why are you allowing the companies to decide what products get sold, what the potency levels are? Why are you just giving control to the companies? Why you could be a lot more restrictive if you wanted to be. So it's interesting in terms of, I get the sense that outside of the U.S., so there are a lot of places that want to keep it prohibited, but there is a lot more interest in some of these middle ground options that can reduce some of the criminal justice costs, but don't necessarily kind of create this for-profit market, right? Because it's like with alcohol, it's the 80-20 rule, Pareto's law. They found with alcohol, it's 20% of the people who consume alcohol account for 80% of the consumption, 80% of the expenditures, right? So if you're an alcohol company, that's who you target. That's where you're going to make most of your money. We did some work for the White House, 7 years ago with respect to cannabis, found almost the same thing. It was 20% of the people who use cannabis. And so this was typically people who use on a daily or near daily basis, accounted for 80% of the consumption. So you have to decide, if that's, if you want to have companies trying to increase heavy use, and that's a choice. And so, so Jared, getting back to your question, what would be the appropriate approach, right? It depends on your perspective, right? So if you're a person who uses cannabis, legalization with this for-profit model, well, it increases the number of options that you have. Over time, it reduces the prices. I know it's taken a bit longer here in California, but outside of California, I mean, we're seeing huge price drops. Like, for example, 60% reduction in the price for flour in Oregon, 40% drop in Michigan. I mean, so it takes some time. So if you're a person who uses cannabis, well, the prices are going down for the most part, more selection, I can have it delivered to me. So for you, especially for someone who's spending a significant amount of their income on cannabis, this is a win. Right. From a public health perspective, having all this advertising and the lower prices and having the companies involved, there are a lot of folks on the public health side that aren't excited about that, and and also in terms of, what's the right policy? I mentioned goals, right? So if your goal was to reduce the size of the illegal market as quickly as possible, well, what you would do is you would give out a ton of licenses, you'd have really low taxes, you try to push those prices down, as a way to where it just wouldn't be competitive for those in the illegal market to be selling. Right. And you move people over. But there are other people that, they're fine if it takes longer to significantly reduce the size of the illegal market. If that means that we have rigorous testing, if it means that we have got taxes, if it means that we don't have the prices bottoming out, right? And so I've noticed that, starting in California, but, throughout the US and other places, I think it's really important for people when they're talking about reforming cannabis laws to be upfront about what are they prioritizing. Because if you understand what their goals are and what their priorities are, it's easier to have a more productive conversation, right? If I know that your focus is on reducing the size of the illegal market, if that's what you're primarily focusing on, that's very different. We're going to have a different conversation potentially than if your goal was to, if the goal was to maximize revenues to the state or something, right? So also, one of the things that's been really encouraging, over the past 10, 12 years is how the conversations about social equity have evolved. And in fact, when Colorado and Washington were initially having conversations about legalizing, social equity wasn't really part of the conversation. People were talking about reducing arrests and reducing, disparities with respect to race and ethnicity, but equity wasn't a big part of the conversation. But then over time, you saw places begin to talk about, well, not only reducing arrests, maybe we need to expunge or seal criminal offenses related to cannabis. And so you saw some places that they would, began kind of heading down that pathway, but then they would still put the onus on the individual. So if you've been convicted, you would have to petition the court. You may have to hire a lawyer. So it still would create barriers, especially for those individuals that didn't have a lot of resources. So then you saw other places begin to say, wait, no, the onus should be on the state. The state should be responsible for kind of expunging or sealing these offenses. And then you've seen other places talking about how they're going to use cannabis tax revenues to address the discrimination, address some of these inequities. And for example, in Evanston, Illinois, they're using some of their cannabis tax revenues for slavery reparations for individuals in their community. And then you've also, in California, other places, there are discussions about license preferences for groups that were disproportionately affected by cannabis prohibition. So I'm really happy in a lot of places now, social equity is one of the main things that gets discussed. Right. And so what I'm hoping in terms of kind of next steps, because there are a lot, if you're thinking about social equity, you've got to make a lot of decisions about, well, what groups am I trying to target? What's the goal? Is it to build wealth in certain communities? Is it to increase employment in some places? So I think the next step, especially kind of from a research perspective, is for jurisdictions to say, okay, let's be clear about what the goals are for these equity programs. And now let's look at 3 or 4 different potential models and let's see which one, is most closely aligned with what we're trying to do here on equity. And so, I think that's where you're going to see a lot of research happening, kind of in the near future as more places begin kind of trying to figure out, well, if I want to maximize our efforts in terms of addressing equity, should I do A, B, C, or D?
Interesting. Another thing, we talked to Scott Wiener about was he had a bill, SB 519, which would decriminalize psychedelics. And kind of what Scott was saying is that psychedelics have been shown to help with addiction and depression issues. Is that kind of what your research has shown, and kind of what can you tell us about that?
Well, I'm glad you mentioned that. I'm just starting to do kind of more work in the space. And so, look, there has been, and I actually listened to Senator Weiner on your pod talking about this just a couple weeks ago. So there's been a fair amount of research over the past 20 years, kind of in environment and clinical environments. So this is research that's overseen by the FDA. In terms of these clinical trials where people will get psilocybin or they'll get MDMA, and then they'll kind of look at for addressing different types of mental health conditions. And as Scott mentioned too, I mean, there was a lot of research happening in the 50s and 60s, and then it kind of shut down in the 70s, 80s, 90s, but really started to pick back up, I say, within, over the past 20 years. So you've got all this kind of research happening showing that for some people, certain substances are having really beneficial effects. And, with respect to depression or with PTSD, I mean, it depends on the population. It also depends on the substance that we're talking about. So you've got all of that kind of happening. But at the same time, you also have different local governments and different state governments changing their policies with respect to psychedelics. And so, I think it really started like 2019 in Denver. And so I think one of the things that's helpful here, Jared, is when people often will use this word decriminalization to talk about a lot of different policy choices. And I think one of the things that's helpful is for people to be very clear about what's happening. So in a lot of places, they said at the local government, they decriminalized, which when we talk about decriminalization, we're typically talking about reducing the penalties. So if you get caught possessing, it's no longer a criminal offense. So when we talk about decriminalization, we're usually not talking about supply. But what ended up happening in a number of kind of local jurisdictions is that what they didn't necessarily, people referred to it as decriminalization, but what they did is that it was more like deprioritization. So they didn't necessarily change the law. They just said, look, it's going to be the lowest enforcement priority for the police and prosecutors to focus on offenses related to psychedelic possession, right? So they deprioritized it. They didn't necessarily change the law. So that's what we've seen in a number of places. But in 2020 in Oregon, two things happened. They passed two initiatives. They passed one initiative which decriminalized the possession of all controlled substances, which included psilocybin, included other psychedelics. And so essentially there, if you get caught with a small amount, either pay up, it's no longer a criminal offense. You pay up to potentially either up to $100 fine, or you can kind of do a screening. If you do this mental health screen or substance use screening, you essentially don't have to pay the fine. That was one of the things that passed in 2020 in Oregon. But then there was another initiative that passed in 2020, which essentially legalized kind of supervised consumption of psilocybin. And so essentially there's going to be separate centers set up throughout the state. They have to be licensed, and those that are kind of administering psilocybin will also they also have to get licensed.
Interesting.
And yeah. So anyway, and they're in the process of setting those up right now in Oregon. It's interesting. In Colorado, in November, they passed an initiative which did two things. Which one, it kind of set up similar kind of what they're called healing centers. So places where you can go for a supervised psilocybin services. But then also what didn't get as much attention is if you're an adult, they legalized possession, cultivation, and sharing of psilocybin and DMT and other plant-based psychedelics. So there, then you can, I'm not sure when it goes into effect, but you're going to be able to grow it yourself and give it away to others. And so that's very different kind of, So it'll be, and at the end of the day, as with the cannabis, this is still all illegal under federal law.
Right.
So you've got all the medical research happening, but then you have all this policy change. And I'd say the one thing, in some ways, it's kind of similar to what we saw with cannabis, in that, you had, a lot of this would start with these ballot initiatives. Then when there was less stigma, the state legislature started dealing with this. But I would say what we're seeing now with psychedelics is much more compressed, right? I mean, it was only a couple of years ago that you had cities started to deprioritize psilocybin, possession, and maybe some other plant-based psychedelics. Then in 2020, you had one state legalizing the supervised psychedelic services. And now you've got what happened in Colorado. So things are moving much more quickly in the psychedelic space.
Interesting. It seems like you get to meet a lot of interesting characters, and a lot of, black market or whatever. Like, do you have any kind of interesting stories of meeting some of these drug dealers or cartel folks throughout your kind of research?
Yeah, I'll end with this one. And so this was someone who I think at one point was pretty involved. And so this was, this had to be 2010, 2011-ish. And it was at that time we were trying to get a better sense of how would cannabis legalization, what would it do to the prices? Right? Because there are a number of reasons why we believe that prohibition kind of raises the cost of doing business.
Right.
And this is big because a lot of the outcomes that get discussed in legalization debates, consumption, size of the illegal market, tax revenues, profitability for businesses, all that depends on the price. And so we had done some work and talked to some people and really kind of made it clear, like, look, when you legalize over time, you're really going to push these production distribution costs down. And that's what we're seeing in a lot of places. It's taking a little bit longer in California, but you are seeing some downward pressure on the prices. But anyways, but I was still we were still, we talked to people, but we were still looking into this. And so at that time, so people know about the Netherlands, right? And so you go to Amsterdam, essentially you could walk into any of those coffee shops and buy up to 5 grams. They kind of consider it kind of legal in the front door. However, it's still illegal to produce cannabis and sell it to those coffee shops. So they say it was like legal in the front door, illegal in the back door. And so, that's how it still continues to operate, although they're beginning to experiment. But anyways, they had a small medical program there. They might have had 1,000 people. But they were producing, I think at that time it was only 4 strains for their medical program. And it was very because it was a medical product, they were spending a lot of time, it was, in terms of really good in terms of pesticides. It was, pretty high potency. I forget what the THC levels were, but one could argue, so this is what, 10, 11 years ago. This was some of the best quality cannabis that was being produced in the world, right for flower. So anyways, I wanted to go kind of check out this facility. So this guy who'd been around quite a bit, he knows who to talk to. So we're driving. And so we're having this great conversation, and I'm learning a ton from him about his experiences in the past. And so like 3 hours outside of Amsterdam, and all of a sudden it seems like we're in this residential neighborhood. Like, what in the heck are we doing? But sure enough, we're in this place, and we actually walk in, and it was the grow facility for this small program, and for this small medical program at the time. And it just was, compared to what we see in California now, this was nothing. But at the time, this was a pretty small facility. And, so they showed me the rooms and where they're growing and everything. They opened up their books to me. And in terms of, the finances, in terms of what does it actually cost to, produce a gram? And so this was 10, 11 years ago, a super small facility, very high quality product. For them, it was about €1 a gram. And so I'm thinking to myself, wow, you imagine some of these really big grows that kind of over time, these prices are just going to drop dramatically. Right. Anyways, but it was a really great experience. I'm with this guy. I don't know where the heck I'm going. I'm like, why am I in this kind of what seems like a neighborhood? So that was a really interesting interaction. And so, it's been, I've spent time talking to people who participate in the industry, those that are on the law enforcement side. And so that's one of the great things about being at RAND, in that we don't have a dog in this fight. We're not coming at this with we have to do this policy or we can't do this policy. And so it really means that it allows me, it kind of creates the space for me to have conversations with a lot of different people that have a lot of different insights.
Yeah. Well, let us know when you go down to Colombia and start doing some research.
I was just in. So I've done a fair amount in Colombia, and in fact, I actually spent time. It was at the time the State Department and I think the United Nations. They actually had separate plots of land where they were growing coca, so then they could test out different pesticides and different things. So I remember flying. I don't even know where it was in the country. Flying out to this farm. And then actually, so not only seeing them grow the coca, but then they actually showed how they actually walked through the process of growing it or producing it, throwing in the gasoline and everything, the whole process. And so, it's led to a lot of really interesting experiences.
Yeah, definitely.
Yeah.
Well, Beau, thank you so much for joining us. Definitely learned a lot. If some of our listeners kind of want to follow some of your work or some of the stuff at the RAND Corporation, how can we get a hold of you or see what you're doing?
Yeah. So, I mean, the website is just, www.rand.org, or you could just go into Google and type in RAND Drug Policy Research Center. Our page will show up. We've got a number of different publications there. And then also I'm on Twitter at Beau Kilmer.
Okay. Awesome, Beau. Well, thanks a lot and have a great weekend. And thanks for joining us.
Thanks so much for having me, Jared. You take care.
Thanks. Bye.